I'd like to introduce the panel. I'm going to let them introduce themselves, actually. We have Cara, we have John on the phone, I believe, and then we have Michael. So we'll pass it over to Cara. Do you want to introduce yourself?
Sure. There you go. Good afternoon or good morning again, everyone. Cara Wahmann, Executive Director, Clinical Operations at HCSC. I'm responsible for our Medicare and our clinical oversight and operational support.
And I'm Michael Lunzer, CEO of Itiliti Health, and appreciate the opportunity to join you all this morning. Just a little bit about Itiliti Health. I'm out of Minneapolis. We have a full suite of solutions for the prior authorization space that essentially help the payer codify and manage their rules and policies. And then we have decision support tools that help the payer make decisions.
And John, are you on
Hi.
the phone?
Yeah, John Roszkowiak. I'm the Director, IT Applications, Interoperability for CenCal Health out of Southern California. And, we're a 250,000 member plan that encompasses San Luis Obispo and Santa Barbara counties.
We may need you to repeat that because Michael in the room is trying to get the volume to come through the speaker a little better. While he's working on that, I'd like to thank Itiliti for the wonderful session that they're sponsoring. And I'm going to see if Michael's doing anything with the sound.
Okay. Got any better?
No. I am going to shut the door.
Yeah. Try again, John.
Okay. How's that? Any better?
It's getting better. Yeah. Just be sure to speak up.
Oh, I will. It's not a problem. Yeah, John Roszkowiak, Director of IT Applications for CenCal Health out of San Luis Obispo and Santa Barbara counties. The small plan, about 250,000 members. And then, so try to provide a unique experience on the small payer side for this mandate.
Thank you. So this session, as you can see, is about digitizing coverage and making sense of the policy transparency mandate. So the three panelists are going to discuss some of the current state digitization policies. And so I'm going to first start with Cara and ask her, what do you see in the digitization? I love that word, but I'm going to start spitting everywhere of policies.
I feel like that's kind of like nebulous, like that's really big, right? Like, what do you see in it? I think maybe like a little bit sideways of that is like stepping away from yesterday and all the conversations we had yesterday about guidelines and content. I went home with like a little bit more uncertainty actually. And as I really started to unpack what all needs to be done as far as digitizing all of our clinical policies and where we're at today, I think, and like I kind of recognize this as we were sitting here yesterday, is that a lot of people I think are focused on, okay, like the health plan's policies, right? Like the health plan has their policies that they're working on. And we have like MCG and we have interqual, right? So like everybody immediately goes to those. And I felt like when we started talking about the hierarchy yesterday, like people kind of actually glazed over. And then there was a lot of people that had questions about it. And so when I think about like digitizing our policies, I think that this is an opportunity for us to discuss how much else is out there that we have to digitize. So like because I probably need a hobby other than interoperability, last night was trying to figure out, okay, so we talk about the Medicare benefit policy manual, right? And there's different chapters of that. And so I was thinking, what do we have to digitize from that? I don't think anybody, maybe Itiliti, let me know if I'm wrong. I don't think that anybody's done that yet. And so like just looking at the Medicare benefit policy manuals, like there would be about 16 different policies if you broke that down, right? Because you would have like the Chapter 9 hospice manual. You would have to break that down into 4 different ones because like care isn't delivered in like these single servings of a guideline at a time, right? Like when we look at medicine and in healthcare, it's not perfectly linear to wrap your arms around somebody. And so it's not a single policy or a single point of care, but it's oftentimes these series of cares. Like an authorization request isn't just one policy. An authorization request for home health care, you have the PT, the OT, the skilled nursing. Each one of those is essentially a different DTR transaction, right? And depending on what line of business is going to depend on what clinical guideline you're using. So I know I'm completely going off script, but it's really resonated with me last night, and I couldn't get out of my head about how much more conversation we have to have about all of these other clinical guidelines that need to be digitized, not just MCG, not just interqual, not even just the NCDs and LCDs. So I probably didn't answer your question, but I felt like it was a really vague question too. So I had a little room there.
Yep.
I think there's just a lot, like we said yesterday, there's a lot to do.
Okay. Michael, do you have an opinion?
Yeah, Cara opened up a can of very interesting conversations. We've been delving into this with our customers around benefit details, not just policy details. One of the things that Itiliti does is our systems unify the is-auth required and the policy relationships, and that hierarchy is so important. So again, that's one topic that's very interesting, is how do benefits and policies around benefits converge with clinical guideline criteria. Another key area of interest is the different sources of policies, again, beyond the health plan and MCG and interqual, but also into digitizing the NCDs and LCDs. And then the one that is very seldom talked about are the state provider manuals. So one of Itiliti's desires, we have a policy management tool. We would like to get to the states and help them digitize their policies, because ultimately, if the policies aren't digitized, it's going to make this very difficult for everybody. So those are areas that I haven't seen a lot of discussion around, and they need to become activated pretty quickly.
And John on the phone, do you have any opinion specifically maybe around the state and federal documents that are already being sent?
Yeah, so it's very interesting. There's a move between a lot of the sister plans in California, the Medi-Cal plans. There's several of us. We've actually done a lot of review and looked at solutions that digitize all of the state and federal. And I mean, the state of California can crank out, policies on a regular basis. I mean, we have a whole review team just to keep up, and they're hit a lot of topics. So we've put plans to put in solutions to digitize that so you can search and also get alerts. Just this mandate alone, the 0057, there's been 6 or 7 APLs, what they call, that the state has put out with guidance on this. So you have to reference back and ensure you're doing your reporting and such. So these solutions are out there. You can digitize them. You can have the ability to search and reference. And then also too, we want to look at is, like, if you have your internal policies, how do you incorporate that into your solutions that they can reference, connect, and then say, this is keeping you within compliance, or you got this date that you need to be compliant and make these reports. So that's ongoing here. Right now we're manual. Some plans are already automated.
Okay, so I have a follow-up to that. For the three of you, where are you seeing the biggest lift?
So, and I know we talked about this a little bit, John. I think obviously it's the state and it's the other manuals, but I think to me too, where it gets really complicated is like not fully established guidelines. So anybody that's familiar with like NCDs, there are, and CMS recognizes this too, there are NCDs that like are not fully established. So they're providing guidance to be able to, more administrative guidance where a service could be rendered or what type of provider could render that, but not necessarily the medical necessity criteria that would need to be associated in approving or potentially denying that authorization. And so, there's this really significant lift, I think, where it's getting through all of these hundreds and hundreds of guidelines that are out there, out of jurisdiction LCDs. What if you have 3 LCDs that all are for the same service code, but the member doesn't actually live or isn't receiving the service in any one of those jurisdictions? How do you decide which one to use? And then how do you create a rules engine to orchestrate that DTR transaction, right? Like, I think there's so much effort that goes into that. I know like health plans are really starting to get their feet wet doing that, but I don't know that anybody's really done it at a large scale when they're, you know, a national plan and they have to deal with state and federal and then all of these other third party guidelines that are out there.
So I would say the biggest lift is time. As Cara just alluded to, there's a lot of detail in these digitization of policies and organization of rules and hierarchies. And it just takes time. It's a detailed topic. It takes a lot of work and effort to go through. And as soon as you have one layer of the onion fully understood, there's another layer of granularity that needs to be identified and worked through. Thankfully, there's 17 months left, but there's only 17 months left. So there's a lot of work to be done.
And John, do you have anything to add?
Yeah, I mean, the effort, and again, I've seen this with other plans. Some of them take 6-8 months to get the data all loaded. It's their CMS mandated information, their state plan information. So once they get it, and also then testing and making sure it's usable data. And, you know, again, there's a couple, I've actually seen some presentations on these solutions and it's quite valuable. But 6-8 months to get it up and running. And that's all, again, time and resources are the question.
Okay, so my next challenge question is to Michael with Itiliti Health. What are you seeing from your clients digitizing these policies?
I think that the key for us is developing a repetitive process. So we've been fortunate to have a number of Blues plans, and they have kind of similar structures to their policies. So we've gotten it down to a science and a regular process where, again, where we see the variance, that's more work to dig through are the state guidelines and some of the LCD kinds of concepts.
Okay. So I'm gonna expand to the whole group, another set of thoughts that have been pre-documented. So this is really easy for me to ask. Not good for you guys to answer though, because it's challenging. How are you thinking about the ROI of this transition beyond just compliance?
So our customers have been able to prove a pretty significant ROI from the CRD transaction. And I think what makes Itiliti unique in this scenario is that our products already do the equivalent of CRD and DTR on the web. So our customers, through their web portals or their provider portal, can perform a CRD. And for instance, in that category, we've been doing that for 5 years. We saw about a $5 million savings annually for one health plan. Another one found that accuracy eliminated $3 million a year in payments that they made to cover things that shouldn't have been covered. So, and that's all pretty simple ROI. The bigger challenge is when you get into policy management, for instance. The policy teams today are are manually working policies between the team that builds the policy and the team that puts them out on the web. So it's a little harder to identify the efficiency benefits there. They're not quite as hard of an ROI. But the place that you see a hard ROI on better policy communication is in the provider's ability to know what to submit. 70% of prior auths that are initially denied and then ultimately overturned are caused by the wrong data or a lack of data being submitted. So if we can help the providers up front to submit all the information and the appropriate information, we can eliminate that portion of the process. And I think when you talk to medical directors at health plans and especially to the physician community, their biggest frustration is peer-to-peer communications. And if we can eliminate or dramatically reduce that, there's a huge return on investment with those very expensive and precious resources.
Others?
No, I think you're spot on. It's getting the right answer, the right time, like the first time on the first pass. Like in my portfolio at HCSC, I not only oversee our space, but also our appeals and grievances space too. And it is oftentimes just that transparency and understanding what clinical information is needed, especially in some of our states or in some of these expedited authorization requests where you only have 24 hours to make a decision. And it's not the health plan who is, arbitrarily like putting a time out there, like we're going to have this to you by this time. We have our own federal and state requirements to be able to get that decision quickly. And so a lot of times it is just getting that right medical or right clinical documents to us to be able to get that approval the first pass. So I think you're spot on that. I feel like that's one of the biggest opportunities across the board for the industry to eliminate waste is by getting the clinical guideline and what documentation needs to be submitted. And if we could be auto-populated right within the provider's workflow also, I think you're eliminating a lot of the touches and the tasks. I think that's another thing is like we don't talk enough about the provider workflow and how that looks and how that feels within the EHR and at the different providers and the different types of EHR that are out there. Being able to back into that or bring those conversations into this room, I think is going to help us to achieve that. I also agree with you. I think that there's huge opportunity in CRD. I think it's something that, it sounds so silly. And somebody said something yesterday about, we can't even tell you if a prior authorization is needed or not. But when you look at the level of complexity and you look at it, especially for the state, a prior there are quantity limits. A prior authorization might not be needed until you get over a quantity limit, and being able to understand and have accumulators in place for that CRD and be able to let people know upfront, you don't need a PA until you pass this many, or this member is about to exhaust this benefit. You eliminate a lot of the confusion and a lot of the additional touches, and you get the right answer on the first pass.
John?
Yeah, the ROI, small plan, it's again, it's people. We're a single line of business. So, we can easily see, okay, we paying claims right or not, but there is value there based on the policies. But the big thing is tracking just the documentation. It's just huge. And then it has to be basically brought in, and then it's forwarded around to the organization, and everybody has to go in manually and look around and say, how does this impact me? So then you've got, 30 people looking at these documents, trying to read them in a timely manner to understand what the impact is. So that's a lot of time and money.
Agree. So I have a question that's going to go to you, John, and then Michael, and then I'm going to move a second kind of question over to Cara. So the first is, what do you think the role of artificial intelligence is in your process with respect to digitalization? I like the L-zation. I'm adding another syllable. John, do you want to start?
Yeah, it's critical. it's got to interpret. I mean, look, OCR scanning technology has been around forever and ever, and we know how inaccurate it is, correct? You know, and then you've had some basic, oh, we're gonna, you know, put in some lines of code to figure it out, but it's not dynamic. So AI looks at this and will be able to identify, normalize, make sense of these documents as they're captured. And also then it helps with, you know, your searching. I mean, you know, you look at, you know, Gemini, you can search and ask a question, it's going to pull up all the relevant information ideally, and which, you know, doesn't exist today with a solution if you have all these policies. Again, that saves you a lot of time, money. You know, your presentation's accurate, and then your searching's accurate, and you can reference it easily. Then it looks at also when you have solutions for authorizations coming in where, you know, the AI is going to be able to search and find based off of codes and give you an accurate, you know, recommendation on the authorization, and it starts speeding the process and doing some of the work the clinicians do in that approval and making recommendations.
And then, Michael?
Yeah, so there's a couple different places in the prior auth world where AI can make a big difference. One of the interesting aspects that we've seen in the marketplace, there are some who are looking at AI to transform policies. And I think what we've heard from customers is they're not comfortable with the risk of that transformation because they've invested so much money and time and science in defining their policies and getting them to a point of giving them an accurate control and a management of care, that AI is not a great way to, you know, fully transform a policy. However, there are places where AI can make a difference. For instance, oftentimes policies are written with ands and ors, and to convert those policies into something that's a little more technically readable, a machine readable document, those ands and ors can be replaced with slightly different operators. That's an example of where AI can, it seems like a really intelligent parser, but that's really what it is it's taking those ands and ors in the guidelines and converting them into something more usable. That level of transformation from AI is something that a human can oversee and verify that the result of the transformation is identical to the intent of the core policy. The other place that AI can make the biggest difference is something John was alluding to, and that's once a prior auth has been submitted, if that policy has been digitized in such a way that each element of the criteria is its own discrete question, if you will, or set of information, you can ask AI to go find evidence in the medical record that the patient meets this described criteria. That's an area where AI can bring a tremendous amount of value, and it's really a super intelligent search model. In the earliest iterations of this, we believe health plans are going to want to have a human in the loop in that scenario where the AI goes out and finds all of those matches and illustrates it really well, helps the human to see what AI found, and then agree or disagree with the AI. There are some organizations that are allowing that to be the decision if it's an approval. We've also seen, though, that in some cases we're seeing government organizations wanting to audit even approvals because they want to make sure that we aren't having positive impact on certain groups and negative impacts on certain groups. So this is where human in the loop is really so important in these earliest stages. The other thing that's really exciting about AI, though, is that every 3 months, it's new and better and stronger. So we're seeing this rapid acceleration of AI capabilities. And so making sure that your architecture and your plan allows for that flexibility to know that over time, AI is going to be able to be injected into other areas of the workflow.
So you touched on something when you talked about overriding the policies when they're digitized and the human component of that. So I have a question for Cara then on the clinician oversight that's needed, because there isn't an omni or solo AI out there. There isn't a standard AI practice for all of the payers, providers, vendors, clearance. So what is your approach there?
Yeah, I think what I've seen demonstrated and what my thoughts are on it is there has to be a clinician that's overseeing whatever the output is, and that is monitoring these things. I personally, Cara Wahmann, don't think that there's ever a scenario where an AI or a bot or a rule should clinically deny a case. I think that it's really, really important, even in like the digitization of the medical policy, because there is like some ambiguous language that's in there. Like if you're just looking at somebody needing a wheelchair, you think that that should be easy, but it might be, like this person can only walk up to 10 feet. They have limitations in range of motion or whatever it is. Or they have some other type of significant debility, right? So like, how does AI identify what other significant debilities would account for this member needing a wheelchair? And so I think that these are things that it sounds silly, like when I think about how we do medical policy now, because it is like this flat PDF file. And then like somebody was talked about it and they explained it perfectly yesterday. And then we send it over to the communications team and then it gets posted and all these things happen. But it's because this is somebody's care. This is somebody getting a service. This is somebody getting chemotherapy, right? Like this could be life-saving treatment that somebody needs. And there are, like Heather said, physicians who have gone to school for this to practice medicine, who are behind the scenes making sure that these guidelines and these policies really are speaking to the standard of care and that there is no misinterpretation. And so I think that there's a great opportunity in different types of authoring and content tools. But I feel very strongly as Cara Wahmann that you cannot take the clinician away from the clinical guidelines at this time. And it is going to be very interesting to see how AI evolves. And how we as clinicians begin to understand that and work with and help train these models, right? And help oversee how these clinical guidelines are maintained.
One additional thought that Cara just alluded to is that this digitization of policies is not a one-time event, right? So once a policy is created and we digitize that policy, 6 months later, there's an edit to the human readable policy, and somehow that edit needs to also be represented accurately in the machine readable policy. So it's really important that the process to get there is not just a one-time ingestion, but ultimately, again, this is where I think Cara mentioned it yesterday, there's a big opportunity here to reinvent the process of creating and managing policies, because it is heavily manual at this point, and really important to tie the maintenance and management of human readable and machine readable experiences together.
Which goes back to one of your earlier points about being repetitive and making sure it's iterative, because medical policies do get updated, usually annually, maybe several times a year, especially when new benefit packages are, broadcasted and sold.
And that's another reason, again, there's so many compelling reasons to change the process, because versioning of policies and ability to reach back in time and find the right policy for a certain date and time is such a struggle in most health plans. And if this process is implemented appropriately, you can reach back in time and find what exactly was the rule and which policy applied on a certain date in history. And a small commercial, that's essentially what Itiliti Health brings to our customers, is a unified approach to that. So,
And that is a perfect segue into the next set of questions that I have for you that have to do with balancing automation and transparency, especially with the digitized policies for prior authorization, the accessibility to clear language and the not getting out of the misinterpretation realm, and then also the transparency for members. How are you guys addressing that? In any order.
So I'll take a first pass at it because I feel like at the health plan level, we are looking at this and talking about it every single day. And there are so many confounding or external influences that are happening right now in the industry. I look at Illinois. I don't know if anybody in here does business in Illinois, then you're familiar with HCAPA. And so Illinois HCAPA is really forcing us to look at all of our internal clinical guidelines. There's legislation now that's out there that says you can only use third-party guidelines. You can't use homegrown guidelines, right? So while we're in the midst of trying to figure out how do we get through and, meet the requirements for 0057 and the digitization and all of these other things, the industry is changing as we're doing all of this stuff. And I think that we're going to continue to see more of that. So to get ahead of it is being, very, very consistent, making sure that we are as transparent as possible. I told you guys yesterday, we did the provider stakeholder analysis, and that was in the top, I want to say it was like number one or I think it was like number two was just the clinical guideline, knowing that up front and having it not be a moving target, right? So it's like, no, like we're really telling you this is the guideline that we're going to do. And then you submit an appeal. And then, somebody says, well, now we're using this guideline, right? Like that's where the problem is. That's where the abrasion really comes from. That's where all of this waste and frustration comes from. So being very upfront, being transparent, making sure our members have access, like our members and our patients, when I was at the bedside, like they're consumers. And they're very, very savvy when we look across all of our lines of business. And even when we look at our Medicare population now, they understand, they have access to technology. I think, years ago, people would think because it was a Medicare member, they're not going to be using technology the same way that our commercial members are going to be using. But that really is not true. They have the same access that any other member has, as well they should. And so being able to have all of that information to them in a digestible way, being able to look at some of our disproportionately impacted populations, right? Making sure that the language level is appropriate and that the content there is in a way that it's understandable and easily accessible. I think it is just like, that is essentially what we're trying to do with 0057. I think that that's at the heart of everything. And I think that we're going to continue to see the industry changing. We're going to continue to see a lot more scrutinization around clinical guidelines, how they're published, how they're written, what types of studies or information goes into building those, and making sure that it's the exact same level of scrutiny or rigor as we see with the MACs and with some of the other organizations.
There's been a really interesting evolution around transparency and care guidelines. Just for one example, years ago, there was this huge concern that if we told the provider what the answers were to the test or what the test was going to be, that they would just answer the questions appropriately and get care. And I think now we've finally gotten to the point where there's a realization, well, if they don't have any sense of the guidelines, we're asking them to guess. It's like trying to drive through a small town with no stop signs and no speed limits, but you might get arrested if you break a speed limit. That just doesn't make any sense, right? So transparency in guidelines and rules is getting better. I think the biggest challenge is payers' data is not necessarily organized that way. For instance, if you do a 270, 271 benefits check, it returns all of the benefits for the patient. It's not a transaction where you can say, I have this particular procedure, is this approved? Or is this allowed? So the transactional data, the processes are not really designed yet to be accurate. So one of the biggest challenges we have as we implement customers is we do make the policy and the rules and the benefits transparent to the member, and they're able to see that information on the web. So if you go to some of our customers, their members have the ability to go in and see, does it require prior authorization? Do I have this benefit, and what policy applies, and what are those guidelines? But then that means that the payer has to live with that answer and can't include a disclaimer at the bottom that says, this answer may be incorrect. You know, we've all seen that on the prior auth requests, that somehow there's a clause that's an escape clause. And that's just not going to work in today's data-oriented world. So member transparency around benefits and prior auth rules and guidelines is critical. And I'd like to kind of applaud the third-party guideline creators, because, you know, years ago, they were very concerned about exposing their guidelines because there's a concern that they're losing their intellectual property. I think it's not fully broken through, but I think in general, we've started to see those guidelines being much easier to get access to. And again, as a provider, if I'm performing a service, or asking to perform a service, I should at least be able to know, you know, oh, I should have done this first, right?
John, do you have anything to add?
I mean, transparency, yeah, you can't say enough about it. I mean, you also think at the member or everyone here, I said, you know, trying to get an auth for a service just to find out if you need one is an effort. So if you have the ability, even if you have to call or go online, like there's some services provided like by other vendors that you can do an automatic lookup of your authorizations and your transparency. With this digitation or the transparency for the being able to store and digitize our documentation, that would make that more valuable to our members. Because I just went through this personally where I was looking for a service and you call, it's a whole hassle just to find out, do I require an authorization, and what does it take to get authorized? So that's a value not only for the provider and the payer to do it right, it's also for the member.
So with a few minutes left in the session, I don't know, Michael, do you want to open it up for questions?
Yes.
We have 3 minutes. Do you have any question? Okay, let me get out there. I got it. Getting some snips.
Are we, you know, one of the things, I have multiple questions, but I'm just going to ask one, and that is, before a health plan looks to digitize their guidelines, their policies, their medical necessity criteria, there seems to be a real need for kind of pruning and not paving the cow paths, as we would say in Boston, you know, to make sure we don't, you know, routinize excessive complexity or dated complexity. Can you speak to the fact that, or can you speak to how, in your experience with health plans, they're approaching this problem? Otherwise, we get, you know, sort of old analog data, some of it useful, some of it less so, being transformed into its digital equivalent, but it may remain every bit as useful or less useful than it was before if we don't do some kind of exercise to simplify and rationalize the guidelines, criteria, and rules that health plans have.
I can talk just a little bit about how our customers have pursued that. We've had some organizations that have gone about the analysis and pruning or fine tuning, if you will, of their prior auth policies and rules before they go into the ingestion process of bringing those into a database. We've had other customers that have done that after they've brought that information into a database. Personally, I would do it after, because even trying to understand what you have when what you have is not very well organized makes it really difficult. But your point is really important, that it's important to be able to look at these from a discriminating perspective.
And I would say too, like even starting with the prior authorization grid itself, right? So looking at your prior authorization grid, really taking a step back and trying to realize, like, why is this on, what is the medical necessity? What is the justification? Really thoroughly investigating your prior authorization grid to make sure that you're only really asking for a PA where it is clinically warranted. I think to me is like the very first step in pruning. And then I agree with you. Like, I would say then start to work with, your vendor to be able to start your authoring process, but then also going back and looking at what the output of that is, because if you're getting questionnaires, you want to make sure that you're putting the easiest one to answer up front. If you know you have to have a diagnosis of short bowel syndrome for this, or all of these other things, have that be the first question, right? Have that be the first data field that's asked. And if you can get a go on one, then why ask all the other 10, right? So I think being really smart and strategic about what is on your prior authorization grid. And then if you are starting to look at your questionnaires and your clinical necessity, like what are those easiest to hit first before you ask for everything else?
I want to add one really good thing about that. One of the things that happens when the policy team that's writing policies starts to see how those policies are being used and digitized, the policies get better and more effective. When we our first implementation, there was a question on our criteria on a guideline that the patient needs to have mild to moderate, whatever, or moderate to severe, whatever, right? And we asked the policy team, what does that mean? And they said, well, if they're applying for a prior auth, they must have moderate to severe, whatever. So it was a pretty ineffective policy or criteria. So they're getting, I think those policies will get better as well.
Any parting thoughts, John?
Hey, as an IT person, I look at things that what makes sense, right? The make it easy for people to read, see, again, just like what the statement was, it's a nebulous policy. It doesn't do anybody any good. What's the criteria? But for me, it's more straightforward of, can I see, we want to digitize it to make it available to the widest audience, to have the organization be the most effective in utilizing it, and then also provide the service to our providers and our members. So, that's my take on it.
Okay, well, thank you to our panelists, and extra special thanks to Itiliti Health for sponsoring the session. Appreciate you three and appreciate the next session that we've delayed a little bit. Thank you.